Morning. Thanks, Aegis, for giving me the opportunity for this presentation. This is the disclosures. Some of the attendings have disclosures. Background, revisional bariatric surgeries are on the rise. They're expected to increase given the high number of primary procedures being performed in US. The complexity of the procedures lead to increased risk of complications compared with the primary procedures. Our objective was to compare the perioperative risk profile of revision bariatric surgery with the primary bariatric procedures in our experience. We did a retrospective review of a prospectively maintained database at our Center of Excellence. All patients undergoing bariatric procedures by 3 fellowship-trained bariatric surgeons were included. The study period was from 2005 to June 2005 to January 2013. The outcomes were 30-day perioperative outcomes and compared between primary and revision procedures. We used Clavien Classification for comparing the complications as well. The data collected included patient demographics, type of initial and revisional procedures, number of primary gastric surgeries, indications for revision, postoperative morbidity and mortality, length of stay, reoperations, and 30-day readmissions. Outcomes were compared using Mann-Whitney or chi-square test, whichever is appropriate. A total of 1556 patients underwent bariatric procedures during this time period, and 102 were revision bariatrics. They mostly fell under these groups. Band to sleeve gastrectomy were 23, band to bypass were 25, VBG and also bypass revisions were 25, and fundoplication to bypass were 29. Look more into the indications for revision. 67 patients had inadequate weight loss following a primary bariatric procedure, and 29 had failed fundoplication, and 3 had anastomotic ulcer which required revision, and 2 patients had significant malnutrition requiring reversal of their bypass, and 1 patient had a band infection. This is the demographics, and on this slide, mainly as you look on the age, the patients on the last 2 sections, kind of more, higher age population, and especially on the last, on the fundoplication to bypass group, the BMI is also lower BMI because the indication is different in these patients for surgery. And I want you to focus on the number of prior gastric surgeries, and as you go down on the list, obviously it increases, and when we compared it, it was statistically significant. The number of prior gastric surgeries in the fundoplication to bypass group were like 1.6 on average. And the length of stay in these patients, it increased as the complexity of the procedures increased. The VBG to bypass and also bypass revision patients had an average of 5.5 days length of stay, and fundoplication to bypass group had 7 days length of stay on average, and other people on the left side, primary bariatric procedures and the band revisions were 2 days on average. Morbidity as well increased as we go onto the right side of the screen. 18% morbidity in band to sleeve, and 20% band to bypass, and bypass revisions were 25, and fundoplication to bypass was 40%. 30-day readmissions as well reflected the same. 20% 30-day readmission in the VBG to bypass and bypass revisions, and fundoplication to bypass was about 38%. And on the band revisions was about 13 to 16% on average. 30-day reoperations, nothing on the band revisions, but on the bypass revisions was about 12%, and fundoplication to bypass was about 20%. Coming to the anastomotic leaks, VBG to bypass and bypass revisions were 4%, and fundoplication to bypass was about 6.8%. And compared to the primary procedures and also to band revisions, they were statistically significant. We analyzed the complications based on the Clavien Classification. Mainly want to focus on the stage 3B, the complication group 3B. 3B means like any intervention requiring take back to the operating room. So as you see on 3B, yellow and red, those are bypass revisions and fundoplication to bypass. 3A is patients who require like an intervention, like a radiological intervention or endoscopic intervention. Those were mostly in those groups. On conclusion, in experienced hands, most revisional bariatric procedures can be accomplished with excellent perioperative outcomes that are similar to primary procedures. And as the complexity of the revision procedures and the number of prior gastric surgeries increases, however, the perioperative morbidity increases as well. And fundoplication revision to gastric bypass represents the highest risk group. Thank you.
As people are coming to the podium, I have a question for you. Regarding your program's approach to the failed fundoplication, can you just talk about that a little bit more? I assume there's some people that did not get a conversion to a bypass that instead got a reoperative fundoplication. So how do you select this approach?
So most of our patients who underwent this fundoplication to bypass were like, they had prior, at least on average, like, they had a Nissen or takedown, redo Nissen, and they had persistent reflex, and we do a thorough evaluation, and they had, on average, they had a high BMI as well. The patients who has high BMI, more than around 35, about 35, 30 to 35 as well, with comorbidities, and persistent reflex following a fundoplication procedure, second fundoplication procedure, then we offer them this fundoplication to bypass.
One more question?
Valerie Halpin, Portland, Oregon. Can you comment on how you managed the fundoplication and whether or not you took it down at time of revision and how you managed the fundus?
So we do take down obviously we had to take down the whole thing. So once we take the fundoplication, most of the times we resect that part of the fundus, and then we do our staple line for creating the gastric pouch. We resect that part of the fundus, yes.
Evan?
Excellent presentation. I have just two questions for you. Since you have demonstrated a little higher risks for the patients that had the fundo to bypass, do you tell your patients something differently when they come to the office? Do you tell them that their risk is going to be higher for that? And then do you do something differently to anticipate for those complications, such as put a feeding tube in that patient population, additional drains for the higher risk population like the VBG and the fundo?
So answer your first question, we definitely talk to them, in detail about, perioperative counseling is really important in these patients. We talk to them. We actually recently published a study on 25 patients who underwent a fundoplication to bypass. In that group, 96% had like a 14-month follow-up with 96% resolution of reflux symptoms. Obviously, it comes with increased morbidity. We do talk to them we counsel them about the complications. And to answer the second question, we do not routinely use the G-tube in the remnant, but if there is if we anticipate there's a high scar tissue, high anticipation, we definitely use G-tube and drains as needed. If there is any concern of any leak on our leak test, we do use our drains, not routinely, yes.
Okay, thank you.
Thank you.